Hello, good afternoon, good evening, good morning, wherever you are. My name is Roxana Mehran, coming to you from New York City, United States, and I'm thrilled and honored to be part of this link session on vasculogenic erectile dysfunction. Today in this session, we want to really focus on how should you approach a patient with vasculogenic erectile dysfunction. I'm very, very thrilled and honored to have with me the experts in the field, Professor Sangiorgi as my co-chair and panel moderator from Italy, Professor Fusco from Italy, another expert who's going to talk to us about some of the guidelines in this arena, and Professor Bistas from Greece. We also will have a talk by Professor Diehm from Switzerland. So without further ado, let's dive in to the topic of vasculogenic erectile dysfunction. We don't ask, they don't talk. Let's get started.
Hello, it's really an honor and a pleasure to be part of the faculty at Link this year. And this session is on vasculogenic erectile dysfunction. We don't ask, they don't talk. A really important issue for our patients who experience this. It's important for you to note my disclosures. Only to speak of is regarding Concept Medical, where we are working on a clinical trial with Concept Medical, but not on this particular topic. So this is a very important quality of life issue for our male patients. And certainly it negatively impacts their quality of life, their self-esteem, their relationships, but most importantly is the depressive symptoms that comes along with erectile dysfunction. What is it? It is defined as a recurrent inability to achieve and maintain an erection satisfactory for sexual intercourse. And the clinical relevance, and why are we talking about this in a link meeting, is that this is a common medical disorder, usually affecting males over the age of 40. It's a major health problem, and with our aging population, our healthy aging population, we start to see a much higher prevalence of this as we go along. The prevalence is estimated to increase from 150 million cases in 95 to twice that, 322 million by the year 2025. A very vast majority of these patients, about 46%, do have ischemic heart disease, but certainly a lot of them, a much higher percentage, do have atherosclerosis. And this is an important relationship why we are talking about it in the link meeting. The risk factors are tremendous. Obviously, vascular ones, including atherosclerosis, venous leakage, most important, 40%, followed by diabetes. And then, of course, there are important medications and pelvic surgery and neurologic and endocrine causes. But interestingly enough, this, like 70% of the cases come to us as cardiologists taking care of diabetic patients with vascular disease. The common questions and myths regarding erectile dysfunction is that, well, nothing can be done. You'll have to live with it. This is expected at my age. Is this a psychological issue? And those are the kinds of questions that we're always thinking about. And perhaps as cardiologists, we don't dive deeply into these symptoms, which are quite prevalent in our patient population. And the fact is that we as cardiologists should know that a normal erectile function requires the intact nervous system, sufficient blood flow, which is what we could help with, a healthy cavernosus tissue, and then, of course, very normal venous drainage. These are important, the four concepts that we absolutely must know about. But the link with cardiovascular disease is tremendous. Up to, I already told you that about the male patients with CAD, but more than 85% of our congestive heart failure patients have erectile dysfunction. And it's really, really important to note that of the men with erectile dysfunction, 75% with CAD have problems achieving erection, and 65% have problems maintaining it. This is also really interesting because erectile dysfunction predates the onset of cardiovascular disease. So most of these patients with erectile dysfunction end up dying of cardiovascular disease. But it's important that when you are making that diagnosis, one, that there are things to do about it, but also to think about the cardiovascular disease and its consequences. So one of the things that has been shown, interestingly enough, in one of the publications is this association of erectile dysfunction and risk of cardiovascular events and MI. Very, very interesting, that needs to be further evaluated. Today in our session, we're bold enough to kind of move ahead. We want to talk about the current guidelines, the European guidelines in treatment of erectile dysfunction by Professor Fusco. We will then move on by Professor Sangiorgi, who will tell us about how cardiologists should approach this. I think it's really important. We need to be brave to start to ask these questions with our patients. And then Professor Diehm will tell us about some of the treatment options from pills to balloons and stents. And balloons and stents are where we here at Link are extremely familiar with. We will then follow with 2 clinical cases. Well, this is going to be a fantastic session, and I look forward to, with my colleagues, to go through this wonderful session and look forward to a vibrant discussion at the very end. Thank you.
Dear colleagues, good afternoon, and thank you very much for this nice invitation. Let me tell you about the current urological guideline on the treatment of erectile dysfunction. This is the 2020 edition of the EAU guidelines on sexual dysfunction. Well, let me tell you that guidelines recognize and confirm this very strict association between the cardiac disorders, a cardiovascular disease, and erectile dysfunction. And ED should be regarded, according to our guidelines, not only as a quality of life issue, but also as a potential warning sign of cardiovascular disease. This is very important. Also in the assessment phase, one of the very few things that we should do in front of a new patient affected with ED, in the basic workup for ED, is to assess cardiovascular and neurological status, because we know that many patients are affected with the cardiac and neurological condition. We also know that every new patient affected with the ED should be assessed for his cardiac risk, because resuming sexual function in a patient who has abandoned sexual activity in the latest few months or few years might be dangerous if the cardiac risk of that man is not well known and evaluated by cardiologists. What about treatment? We know that before any therapeutic suggestion, we might identify patient needs and expectation. And let me tell you that in most of cases, patient expectation is to be brought back to normal. Please, doctor, make me back to normal because I want back my erection. This is a usual expectation, the most frequent expectation, and believe me, it's not easy to make patients happy about that. And later on, we must identify and treat the very few curable causes of erectile dysfunction, which is basically a few hormonal conditions like low testosterone or hyperprolactinemia, and some purely psychogenic ED cases. Then let's improve risk factors and change lifestyles. In that frame, we are very similar to what we do in your cardiovascular disease patients, because risk factors are the same and lifestyle modification should be the same, like improve physical exercise, reduce body weight, cessation of cigarette smoking, and whatever. So I think you are familiar in this context. And finally, provide education and counseling to patient and partner when the partner is available. But eventually, we need to prescribe a treatment. And in vast majority of cases, the prescription would be an oral therapy with PDE5 inhibitors. However, in the same line of treatment, we might also consider other solution, which is intracavernosal injection, vacuum device, topical prostadil, or low-intensity shockwave treatment. And either treatment or a combination of this treatment might be successful in improving sexual function and quality of life in our patients. Sometimes this is not enough. Some patient is resistant or is unsatisfied with every treatment, every possible solution. And the final shore is a penile prosthesis implant, which of course can solve also the most difficult cases. However, the erection that it provides is not the most natural and spontaneous compared to the normal sexual function that the patient like to be back. What about vascular treatment? Let me tell you that current guidelines consider vascular surgery as a treatment for ED only in young patients with pelvic or perineal trauma. So short segmental stenosis of pudent artery due to trauma, well, that cases might be revascularized and the success rate might be good. However, no other mention is made about endovascular treatment of ED, although it is considered a symptom of cardiovascular disease. So even if we have a number of effective treatments, many of these treatments are non-etiopathogenetic, they lack of spontaneity and naturalness of sexual activity. Therefore, there is a wide room for an endovascular treatment of ED, but as guidelines do not mention it, we should be aware that endovascular treatment of ED is a new journey, something we are beginning now as pioneers, but I'm sure that at the end of the journey, we will have a great success, we will have a great benefit for the medical community and especially for our patients affected with erectile dysfunction. Thank you very much.
Okay. Good afternoon, everybody. Let's take a quick look on how cardiologists should approach patients affected by vasculogenic erectile dysfunction. This is my disclosure slides. First of all, we should approach this patient with sexual clinical history that should be always conducted in a culturally sensitive manner, taking into account the patient background and lifestyle and status of the partner and the relationship, and of course, our personal comfort and experience with this topic. The sexual inquiry should be incorporated, I believe, into all new patient encounters when possible. And you only need to take two simple questions and get information if the patient first is sexually active or if the patient needs to discuss with you some sexual concerns or problems. Of course, there are some reasons related both to patient and clinician for not taking a sexual history. There is a lack of opportunity, usually for the patient, a sense of embarrassment or shame and social taboo against the open discussion of sexuality, and also uncertainty whether sexual problems or concerns are part of healthcare. For us as clinicians, there is always time constraint during outpatient setting, an unrealistic fear to offend the patient asking sexual questions, a deficit in communication skills, and especially for female physician discomfort about asking sexual questions to a patient of the opposite gender. However, a clear description of the problem is vital. So we should get information whether the patient has difficulties in obtaining an erection, whether erection is suitable for penetration or can be maintained until the partner has achieved an orgasm, ejaculation if occurs, and the sexual satisfaction of the patients. You usually will encounter two types of scenarios. The patient may have problem of tumescence and penetration. This is, of course, a clear indication for arterial insufficiency, or the patient has an erection maintaining problem. And of course, you do have, in this case, a venous insufficiency. Keep in mind that, of course, mixed problem can be, of course, always be present. We usually utilize this type of questionnaires, which is called International Index of Erectile Function, 5 questions, 5 scores. You may have from 6 to 10 severe erectile dysfunction, and up to absence of erectile dysfunction if the score is greater than 26. You should be able to understand the dynamic Doppler that it's usually done by urologists, where you can clearly identify arterial insufficiency when the peak systolic velocity is less than 25, or venous insufficiency, where end diastolic velocity is greater than 5 centimeters. You may submit patient to angio-CT, where you can clearly identify the presence and location. Just keep in mind that in the majority of the cases, you will find atherosclerotic disease of the pudendal artery in the zone 4A, 4B, and 5A, so proximal, middle part, and distal part or dorsalis penis artery segments. When you bring the patient to angiography, you may perform also CO2 angiography in panel B. You have a clear identification and opacification of CO2 of the cavernous body, while in panel D, you have absence of CO2 distribution, indicating a fibrotic cavernous tissue. These are the projections that we usually perform during selective catheterization of the pudendal artery. We start usually in AP projection, then we move to homolateral 45 caudal or 45 cranial projection. We are able clearly to identify the distribution of the pudendal artery. So in conclusion, I think that as a cardiologist, we should always take sacral history during patient examination due to the relation with the ischemic coronary artery disease. This is usually first symptoms for also coronary artery disease. Just remember that the rule, if we don't ask, they don't say. It's always true in this setting. IF questionnaires and dynamic Doppler examination are usually sufficient to make a clear diagnosis of vasculogenic erectile dysfunction. And when you bring the patient in the cath lab to perform selective contrast media angiography, you may also want to do a CO2 angiography in order to rule out fibrotic cavernous disease, and also to obtain detailed information regarding the presence and the location of atherosclerotic plaques. Thanks for your attention.
Thank you very much. It's my great pleasure to discuss with you my personal experiences of treatment for arteriogenic erectile dysfunction. These are my disclosures. Now, the primary treatment provided by both urologists and general care physicians mostly consists of PDE5 inhibitors and or intracavernous injections of prostaglandins. Of note, PDE5 inhibitors have no or only suboptimal response in up to 50% of all ED patients, and they may be associated with relevant side effects of up to 25% of patients. In addition, in my personal experience, if those vasoactive medications do not work, the presence of a vascular problem is very likely and merits further workup. So we have no time to discuss here the dedicated vascular workup with ultrasound and CT scan, and we directly go into our endovascular experience. However, I want to clearly point out that we favor an interdisciplinary setting with a urology workup prior to a vascular workup, just to rule out urological causes of ED. And we also recommend a cardiology workup, as you will see later on also in my cases. So this is a paper that was published in the Journal of Endovascular Therapy in 2019 as an all-comers quality control investigation, including 50 patients with 82 lesions treated with POBA, drug-coated balloons, and DES, in line with our initial experiences from April 2016 to October 2017. And the primary safety endpoint, also in line with the previously published SEND trials, was freedom from major adverse events at 30 days and 3 months. And the primary feasibility endpoint was so-called minimal clinical improvement based on the IIEF-6 score. That is a questionnaire on erection-specific questions. And this was done at 3 and 12 months. And these are the clinical characteristics and comorbidities, and we won't go over this in great detail, but this is just to show that within this all-comers investigation, there were multiple concomitant risk factors with potential impact on erection, just as use of beta blockers, hypogonadism, and so on. So this is an all-comers series. This has to be kept in mind, especially when we look at the outcomes. And these are the procedural and angiographic characteristics showing that these lesions treated in the pudendal and penile arteries were comparable to coronary type arterial obstructions. And we, as already indicated, treated those initially with POBA, drug-eluting stent, and DEB. What about the clinical outcomes in these patients? You can see on these slides that we have shown an improvement of erection at 3 and 12 months in about 2/3 of all patients included in this all-comers registry. So no relevant response in up to 1/3 of patients. And if we take the endpoint definitions that had been utilized in the Viagra study published in the New England Journal in 1998, the clinical outcomes were a little bit better when compared with this so-called MCID endpoint that has been utilized in a variety of endovascular trials. What about restenosis after the application of drug-eluting stents? This is a paper that is currently in press in the Journal of Sexual Medicine, published by our group, on 100 patients, all being treated with a single and novel Sirolimus thin strut eluting stent. And in that series, we had the opportunity to re-angiogram lesions in patients undergoing staged procedures in 24 patients with 52 stented lesions at around 9 months. And within this time frame, we have shown that binary restenosis is 15.4%, so significantly lower when compared with an older stent that had been investigated within the SEND trial. So in summary, the restenotic propensity compares quite favorable to other small diameter arteries utilizing a novel drug-eluting stent. Why do we use stents at all? I have shown you that sometimes even very young patients may be affected. We had some own experiences with recoil. So in general, the pathobiology of small caliber artery restenosis is still not fully understood. We have these issues also in the coronary arteries, and we have seen this in an earlier publication in the below-the-knee arteries that are, at least when it comes to diameter, pretty comparable with those arteries of erection, with those erection-related arteries. So in the below-the-knee area, recoil is pretty frequent, and we studied also recoil in the pudendal arteries. This is just a clinical example of a proximal pudendal artery. You can see here the angiogram prior to angioplasty on the left-hand side. Then we dilated this artery with a 3 millimeter balloon and obtained on the right-hand side a very nice acute result at 1 minute. However, if you wait for 10 minutes, you see that there's substantial recoil already in this early time frame. And this is why, after initial experiences with recoil, we started adapting a primary DES strategy at this stage of endovascular intervention for erectile dysfunction. We published our experiences in another paper in the Journal of Endovascular Therapy. This is just a small series of 21 consecutive ED patients where we were waiting 10 minutes subsequent to plain angioplasty, and if there was significant recoil, we stented these lesions, and ultimately we found a severe, that is more than 30% luminal reduction recoil at 10 minutes in 45% of arteries treated. So in my opinion, at this early stage of endovascular therapy, we feel much safer utilizing a thin strut drug-eluting stent rather than just dilating or rather than utilizing drug-coated balloon. But certainly further studies will be coming up investigating different anti-restenosis therapies. So I may conclude that endovascular therapy is a good treatment option in patients not responding to any vasoactive agents. At the moment, a primary endovascular treatment in patients responding to PDE5 inhibitors is not recommended. There is no randomized comparison of Viagra versus stent at the moment. And we have to make further studies to better define those patients responding to vascularization. I've shown you that about 2/3 of patients do exhibit a benefit. Right now, we don't know which patients don't exhibit a benefit subsequent to vascularization. And also a variety of studies needs to be conducted to define the best anti-restenotic concept in these thin arteries and in frequently younger patients and those that we see for PAD treatment. Thank you very much.
Okay, let's move to some case example. This is my disclosure slide. As a first case, this was a 61-year-old hypertensive diabetic, non-insulin dependent for 10 years, and now insulin-dependent diabetic and hypercholesterolemic. In 2017, a patient experienced non-ST elevation MI, and it was treated with 2 drug-eluting stents on the LAD and LCX. The patient onset of erectile dysfunction started in 2016, and the patient was not responding anymore to PDE5 inhibitors from 8 months. We tried Chalice 20 milligrams on demand plus Chalice 5 milligrams once daily. The IF5 score at the time we have seen him was 8, indicating severe erectile dysfunction, and of course he was submitted to selective pudendal angiography, which is shown here. You can see that the catheter, this is a right juttings in the internal iliac artery. You have the external gluteal artery on your right, and the pudendal artery, as you can clearly see, it's completely occluded. This is the procedure. So this was a CTO. We crossed with a Samurai 0.14 wire the pudendal artery that was treated with first pre-dilatation with plain old balloon angioplasty, and then with Sirolimus eluting balloon, so Magic Touch ED, 2.0, 20 millimeter of length for 3 minutes, obtaining this type of result. You can clearly see that the pudendal artery now is completely reopened, and on the right you have the 6-month follow-up. We got a delta IF score of 18 points, meaning that the patient moved from severe erectile dysfunction to very light erectile dysfunction, and is now taking Chalice only on demand. Of course, talking about Magic Touch ED, as you know, this is the only approved for this type of indication, Sirolimus saluting balloon. You know the device probably very well, but just for a recap, you have a Sirolimus that is converted into submicron-sized particles. These particles are encapsulated into a highly biocompatible drug carrier made by phospholipids. And of course, this will protect, the phospholipids will protect the Sirolimus and making it able to cross the intimal layer and the endothelial barrier due to the fact that by coefficient diffusion, the Sirolimus is able to cross and enter into the vessel. On the upper right panel, you have a clearly demonstration of this with the staining of the Sirolimus that you will see in the intimal layer at 1 hour, in the medial layer at 3 days, and 7 days in media and adventitia layer. Another case, another 54 years old hypertensive, diabetic, non-insulin dependent guy, normal cholesterolemic. He had never experienced any cardiovascular events. Coronary angio CT was negative. He experienced erectile dysfunction since 2018, not responding anymore to PDA5 from 1 year. He tried Spidra on demand plus Chalice 5 milligrams once daily. Patient also was submitted to low-intensive shock wave therapy. As you have already heard, these are another first-line therapy that is recognized by the European Urologist guidelines, but however, he had no beneficial effect with this therapy. IF5 score was 6, and he was submitted to selective pudendal angiography. You can clearly see the pudendal artery disease, a very diffuse disease in the mid part and in the distal part of the pudendal artery, which is outlined in the inset here on the right. We treated this patient with a drug-eluting stent in the mid-distal compartment. In particular, it was a 2.5 18 millimeter Cruz drug-eluting stent implantation. And you can see the drug-eluting stent in the mid and part of the pudendal artery. However, we also optimized the drug-eluting stent with non-compliant 2.5 balloon inflation. And then, of course, we treated the distal part with the Magic Touch ED 2x20 inflation for more than 2 minutes, and you can clearly see the result at the end compared to what it was before after drug-eluting stent placement. What is the future of this type of treatment? Right now, there is a registry that we are doing. It's called Suation, so Sirolimus saluting balloon utilization for treatment of vasculogenic erectile dysfunction, which is a prospective, non-randomized, all-comer, multi-center, single-arm study with this type of efficacy endpoint, a composite endpoint of delta international IF score greater than 5 and a delta Doppler peak systolic velocity greater than 5 centimeters per second at 6 months follow-up. Safety endpoint, freedom from target lesion target vessel revascularization at 8 months follow-up, and 100 patients will be totally enrolled. These are some preliminary results after the first 37 patients reach the 6 months follow-up. You can clearly see the success, clinical success in 70.4% of the cases, with a delta Doppler of 68% of the cases, and improved more than 5 IF score in 73% of the cases. A randomized study will be start soon, also with this technology, with a sham procedure and a crossover after the index procedure. Okay, I would like to conclude that the PTA of the pudendal district will be technically demanding. However, good results could be obtained with sirolimus eluting balloon or stenting as intention to treat or bailout strategy. And of course, we need future registry and randomized clinical trials in order to prove that this type of mechanical revascularization can be adopted as a second-line therapy in vasculogenic erectile dysfunction. Thanks for your attention.
Thank you very much. The first case is about a 51-year-old former soccer professional that was physically in very good shape and in which I could not picture atherosclerotic changes of iliac arteries. His risk factors were limited to a positive family history of cardiovascular disease, and his IIEF 15 questionnaire showed severe ED with 29 of 75 points at baseline, and he did not respond to PDE5 inhibitors, and this is why he showed up for vascular workup that showed an impaired penile arterial perfusion subsequent to the intracavernous application of Caverject, and we found a newly diagnosed hypercholesterolemia as a potential cause of arterial ED. Subsequently performed CT angiogram showed a significant calcification of the right pudendal artery, but no coronary artery calcification. And this is the selective angiogram of the right distal pudendal artery showing a very focal high-grade stenosis. Here on the right-hand side, you can see the image subsequent to drug-eluting stent placement that left the patient immediately with a complete restoration of erectile dysfunction, and he did not even need PDE5 inhibitors anymore, which is not the case for all patients. So patient happy. However, at 1.5 years later, this patient was readmitted to our hospital. Remember that we had no evidence of coronary calcification in this patient that was obviously treated with aspirin and a statin. However, he then experienced an acute MI with an occlusion of the LAD only 1.5 years after the treatment of ED. So this is just a short second clinical, it's not actually a case, but a clinical vignette showing what we frequently find in these patients, that is that the pudendal artery arises from the inferior gluteal artery. And if you have an arterial obstruction of the inferior gluteal artery that is proximal to the pudendal, you may have both gluteal claudication and erectile dysfunction. So always ask these patients whether they have concomitant gluteal claudication, which may be explained by this frequently observed anatomical pattern. So this is another astonishing case of a 17-year-old patient coming from the Netherlands with erectile dysfunction, non-responsive to PDE5 inhibitors and non-responsive to the Caverject application, which we did in the practice. He reported about having smoked about 10 cigarettes per day only since 6 months, but also regular cannabis consumption since 2 years. On vascular workup, we were shocked to see that he didn't have an appropriate erection subsequent to the application of prostaglandins, and also he had diminished arterial flow patterns, and the CTA showed, to our surprise, in this 17-year-old patient, a high-grade obstruction of the left internal pudendal artery. This is the angiogram that was obtained with nitro intraarterial. So this is not a spasm, but this is a highly stenosed proximal pudendal artery. On this image, you can see that the pudendal not always comes from the inferior gluteal, but this is a separate offtake from the hypogastric artery. Obviously, in this young guy, we tried to avoid the need for a permanent scaffold, and we treated only this patient with a DEB for a complete restoration of his erectile dysfunction. So with these cases, I may conclude that you should not underestimate the cardiovascular risk of seemingly healthy, non-atherosclerotic, just from a clinical standpoint, ED patients. Many patients have atherosclerotic alterations of their inner iliac arteries that you may not expect just from a clinical point of view. Always ask these patients for concomitant gluteal claudication when you work them up. And I've shown you that arterial ED as an expression of vascular inflammation likely due to cannabis consumption can occur also in very young patients. Thank you very much.
Well, welcome back, and I hope we were able to give you a glimpse on this very interesting field and pioneering application of this technology. I had the chance to reply to some questions online, but I would like to start the discussion with all the panelists. And of course, I take advantage of the presence of our urologist, asking him, how is the workup when you see this patient affected by ED in your specific field?
Well, thank you for the question. In most cases, the workup is very basic. History taking, you might also use questionnaire, but let me tell you that outside of clinical studies, questionnaire is not always used, because you just ask the very same question you have listed, and you can make the diagnosis of ED just during the anamnesis. Then focused physical examination, external genitals, and you look for signs of hypogonadism, which might mean bad distribution of fat or air, or maybe little testicles, little penis, or whatever. And also, you ask him if he knows to be affected about some neurological condition, because you cannot make a neurological diagnosis, you just ask him. And if he's affected about from any cardiac condition or cardiac risk factors. That's all. In vast majority of cases, that's all. And the only thing you might ask more is blood test for glycemia, so fasting glucose, and testosterone. That's all. If you have a patient which reports a risk factor, for example, diabetes, maybe previous myocardial infarction, hypertension, it will take some drugs, for example, antihypertensive drugs, well, that's enough to consider his erectile dysfunction as an organic erectile dysfunction. Psychogenic erectile dysfunction is suggested when you do not have organic risk factor. So there are suppositive diagnoses. In the vast majority of cases, this is enough to start the treatment without doing any invasive test or any more accurate test to assess the etiology of ED in that specific case.
So you do not routinely perform a dynamic Doppler in those patients?
No, not at all. Not at all. This is just a step forward, but history taking, physical examination is enough to start a treatment. Of course, to start a non-invasive treatment.
So I think that, the first message is that we should bring at home is that we probably, as urologists, you probably as urologists needs to, since now, we have shown that the majority, at least 40% of patients may do have an organic disease, atherosclerotic disease, is to perform a dynamic Doppler that can strongly indicate that there is an atherosclerotic disease in the pudendal district.
Yes, correct. Even because, at the beginning, you just want to know if there is room enough to prescribe a PD-5 inhibitor, so you don't need to go for a Doppler, which is not always to perform, because, a dynamic Doppler of corpus cavernosum requires injection of vasoactive drugs, so it's an invasive procedure, and you should do it only if you really need results. If the results of that exam changes your treatment, which is not the case at the beginning of the treatment plan.
I really want to, underline that the patients that we are currently treating with the mechanical revascularization are patients who do not respond anymore to PDA5. This is in agreement with our urologist. So we reserve this type of treatment to those patients. I would like to ask Theo what was his experience as an interventional cardiologist in order to start a network and a program of ED treatment in the cath lab.
Well, the problem was that at the moment in Greece, the majority of the people, they are looking for a solution for their erectile dysfunction to their urologists and andrologists. And due to the fact that the evidence are still very encouraging, but we don't have really this level 1 data, it was difficult to convince them. But at the moment, we are going to start this program also in Greece, let's say in cooperation with interventional radiologists and vascular surgeons, in order to provide this kind of multidisciplinary approach. And I really like this, let's say, the design of this team that we are at the moment in the front of the audience, that we have a neurologist and we have a cardiologist together in the same tunnel. And this is the way to go forward in the near future. And I would like to have a very, very short question to you, Giuseppe. To those patients that you are treating at the moment, these are technical questions. I saw that you're selecting your balloons stents between 2 and 3.5 millimeter when you're going distally. The point is, we know that if there is no touch, there is no drag. How sure are you that it is the 2 millimeter balloon? Have you any measurements with OCT or IVUS to be sure that this is the right diameter?
This is a very good question, Theo. We started to perform intravascular ultrasound and OCT in order to better characterize the type of plaques. By experience, I can tell you that the proximal pudendal artery goes from 2.75 to 2.5, and then the artery is usually tapering, going down to 1.5 millimeter in the region of the dorsalis finis upper. We received the note from the main arena that we need to wrap up. I really hope, first of all, thanks to all speakers and panelists that have participated in this very nice glimpse on ED treatment. And I really hope that the audience have enjoyed the talk to start a program in their own hospital with this mechanical revascularization of erectile dysfunction. Thanks a lot, and good evening to everybody from Rome.